Welcome back to Care Transitions Today. This is a healthcare podcast with a focus on case management and transitions of care. The podcast is presented by the American Case Management Association, and I'm your host, Deb McElroy. Before we begin, I'd like to do just a quick message from the American Case Management Association, ACMA. Is your company interested in exhibiting at the 2021 ACMA National Conference? It's coming up soon, and we would love to have you join us June 22nd through 25th in Orlando. In addition to providing continuing education, the conference hosts an exhibition which allows attendees time to network with representatives from external facilities and those facilities that provide resources, services, and products that are critical to patient care delivery systems. You can learn more at casemanagementconference.com, and I'd encourage you to take a look at that as we're getting back to life somewhat post-COVID. So please take time to take a look at casemanagementconference.com. Just a reminder, the theme for this season of Care Transitions Today is centered on innovation in all aspects of case management and transitions of care. Today's episode will focus on the implementation of a new pediatric risk stratification tool. The project won the most innovative poster presentation at the 2017 National ACMA Conference, and I'm delighted today to welcome Sarah Bradshaw, who is the principal investigator for the research and development of this tool. It's called the HARRPS Tool, the High-Acuity Readmission Risk Pediatric Screen Tool. It's a mouthful, and I'm going to let Sarah tell you more about that. She is an accredited case manager and certified pediatric nurse. She's worked in a variety of pediatric healthcare settings and has been with Children's Mercy Hospital in Kansas City for over 8 years. And welcome, Sarah. Thanks for joining us today. I am going to just start with one of the things that excited me about this project is in 2019, ACMA released its standards for transitions of care. And the first standard is identify patients at risk for poor transitions. And that certainly highlights the work that you've been doing and the value of a validated risk assessment tool, which you've been working on. So welcome. Tell us a little bit about yourself, and just can you talk as we start off the day about some of the drivers that even prompted trying to develop this tool?
Yes, thank you for having me. We're always so excited to be able to talk about our tool and how we've gotten there. It's definitely been a journey. So when we talk about the drivers, it actually started all the way back in 2015. At that time, just kind of give some background of where our organization was. We are a standalone pediatric facility. And at that time, we were really more focused on a discharge planning model. So we had discharge planners instead of care managers. But in 2015, we were making that switch, learning how to be a care management department. So there was a core group of us viewing the literature, going to ACMA conferences, and trying to learn and find out just at a general level how to provide the best care management services, really following those scopes of practice for care managers. One of those key practices is screening patients, not just for risk, but also trying to identify who needs care management services in an inpatient setting. So many of us back in 2015 were going out and saying, okay, what are the tools, what are the resources that we can use as we develop our care management program? At that time, there was a few adult screen tools that were presented, but none of them quite fit the pediatric population. All of them have specific questions to the adult care that aren't really evidence-based for those pediatric patients. So I think at the time we were hopeful that we'd be able to find a tool and just implement and use, but quickly realized that that tool did not exist and that we needed to and had the opportunity to create a tool. So that's really where our journey started. And then it's really grown throughout the years.
That's great and exciting because I was involved in the development of the standards for transitions of practice, and I think it's so intuitive to know that you need to do that risk screening, right? But you
Yes.
were actually changing your model, as you said, from more discharge planning or episodic planning to really managing cases. So the story of that beginning of the journey is exciting to me personally. So I think it started as a quality improvement project, if I'm correct. So tell us a little bit about that and how it was structured. And then I know it grew, right?
Oh, yes.
and really developed into a full-blown study. So take us through how that worked.
So really, we are fortunate to be part of an organization. We have resources to experts in quality improvement as well as research. So we relied heavily at that time on those mentors to tell us what avenue, this is the information we're looking for, what avenue is more appropriate. Is the quality improvement track right now the most appropriate track to be in? Or when does it become research? And so it really started out in quality improvement because we had this brand new tool. It's never been used. And so we had to do a project in which we start using the tool. So we are really starting to adjust and make changes to how people do their job. But not only starting to use the tool, but we needed to get our care managers to use it correctly. So we could trust that the information being collected on the screen tool was accurate. And so at that time, the quality improvement project focused on how could we get this tool to be administered or be completed on every single patient admitted to Children's Mercy. So we have about 350 beds approximately. So those are constantly revolving. And so that was quite the caseload to expect every care manager to start their day by finding those new admissions and doing this screen on every single patient. So that's really where the quality improvement project started. We had to get it up and get it used. Once we knew that tool was used and we knew the staff were using correctly, then we had to go into research to figure out, can we test the validity and reliability of the tool? Meaning, does this tool even predict readmission risk, or where are we just asking arbitrary questions? So that's where it morphed into research. We had to take it to research to really make sure we could trust the tool.
I want to just circle back a bit to talk about timeline, because I know folks are interested to see how this is developed. So when you think about how long it took to develop the actual tool, can you walk us through that?
Yep. So back in, again, about 2015 was really our discovery phase. We were out trying to find if a tool existed, and that was really our discovery phase in which we identified a need. I would say it took about 6 to 9 months in 2016 to really go deep into the literature to find those elements that were associated to readmission risk for pediatric patients, and take those elements to make them questions in the tool. At that time, we were approaching kind of the fall of 2016, in which we ran our quality improvement project. Quality improvement projects have the beauty of moving at a fairly rapid pace if you need them to. So we implemented the tool at Children's Mercy in that very I would say draft state, or the state we were doing in the quality improvement project, the fall of 2016. And that lingered probably into the springtime of 2017. So really at that point, you're looking at about 1.5 years time period between the discovery phase, creation of the tool, and implementing of the tool, or beginning to implement or interweave that tool into the practice of our care managers.
Okay, good. That just gives some context. And then I have one other question before we get into the specifics of the tool. So you have a good size organization there, right?
Mm-hmm, absolutely.
A system, and you talked a little bit about there's a lot of churn in that system. Did you get pushback? You're talking about using a new tool with already busy folks. And obviously this was pre-COVID, but it busy. And so how was that? How was it received? Were people, was adoption of the tool easy or not?
I think we got lucky. Kind of hindsight, sometimes 2020 year makes it look a little bit better, but we had a very strong champion team stemming from our executives all the way through the director of care management at the time. They saw that need. We were in that period of transitioning from discharge planning to trying to develop our care management model. And so even though the quality improvement in research was specific to a given tool or a screening, it was just part of that bigger picture of transitioning to a care management model. So that champion or that director and the executive team really helped to, if we did get pushback, to say, hey, this is part of the larger initiative. But honestly, part of that quality improvement project was talking with all the care managers and saying, we don't want this to be a burden to you. How can we improve the tool or put pieces in the tool to bring the information up front for you? So this isn't taking away or taking substantial amount of extra time on your workload. Honestly, through the tool, we were actually able to gather data and identify which ones of our medical teams are kind of more needy or needier than others. And it really actually ultimately helped gain more staff. So when you talk about extra burden in the interim phase, yes, it was a little bit extra work, but long-term, it actually ended up resulting in a few extra staff.
That's great. That's great, because I'm sure that they, it's hard to quantify where you need those FTEs, right?
Mm-hmm.
So I would think that there was a lot of folks ultimately then applauding this effort. That's great.
Yep. And it, it really helped identify those patients that could use a non-licensed care management staff over a nurse or a social worker. So it really helps bring forward or bring up front what type of care do we foresee for this patient as they progress through their stay with us.
Okay, that's an interesting piece, and I want to come back to that in a minute. I think to have folks really understand this, can you get into a few more specifics on the tool itself? What are some of the metrics? Is there something that got tossed, as you walk through the quality improvement / study journey? So what were the changes? But can you talk about the tool?
Yep, absolutely. So the tool, when we were in the quality improvement phase, was really comprised of 9 categories or 9 questions stemming from the literature. That included the patient's admitting diagnosis. Sometimes in the literature, it's also referred to as the chronic condition indicator, or how many chronic problems does the patient have? What language do they speak? What's their acuity of their admission? So are they being admitted to an intensive care unit? What's their readmission history? Are they constantly coming back to us within every 30-day cycle? Sometimes those are known as, our frequent flyers. What type of insurance do they have? Are they a Medicaid, Medicare patient, private or commercial insurance? Are they self-pay? And then do they have any home equipment, home nursing, or home therapy? So that was the tool, or the general concepts of the tool, as we moved from quality into research. And so when we looked at the research and the metrics or the outcomes we wanted to see from the research, one, we had to evaluate all 9 of those and to say, and look at them individually and say, does this question have statistical significance to remain in the tool? So that was question 1. 2, once we knew the questions that were going to stay in the tool, what value, what number does that question get? Because some questions have a higher weight in the association to readmission risk. And then 3, once we were able to give each question a value, was taking those values and comprising them together to make an overall risk score. And then really kind of that the end of the 3rd step, or maybe even a 4th step of, now we have an overall risk score. What does that mean? What score makes someone high risk versus moderate risk versus low risk? So really, when we looked at metrics, it was a stepped approach. I think one of the changes that resulted out of the research was the identification of one of the questions needing removed. So what we found in the literature was that English versus non-English speaking patients had a different readmission rate in the pediatric population. Our research showed that there was no statistical significance. We even asked our statistician to look at that a couple different times just to make sure. But that was a little bit of a surprise to us. But as part of research, and our mentors taught us, is you have to release your own biases in research and really let the data show you what is presented to you. And what was presented to us was that patient or caregiver language was not statistically significant for this tool. So that was one of the questions removed during the process.
That's great. So you talked about some evaluation of case management resources, right? Your certified case managers versus someone that an unlicensed person could help navigate some kind of a case that an unlicensed person could contribute to. So how does that work and what does that look like? Because I know with the transition of care standards and with the burden that is on all of us, we have a strong belief in the right certified case manager taking care of folks, but we understand the application of non-licensed. So how does that look in your environment?
Yeah, absolutely. Every organization comprises their care management department a little bit different. Ours are comprised of team coordinators. Those are our non-licensed care management staff, nurse care managers, social workers, and nurse utilization review specialists. When we look at the tool and how does that intertwine within our model, the tool was able to stratify patients into 3 categories: low risk, moderate risk, high risk. No matter what risk level you're in, you have a team coordinator involved in your care. Our team coordinators are our backbone in coordinating follow-up appointments for our patients. And when we look at our inpatient psychiatric transfers, they're facilitating those transfers every day. So they're really involved in the majority of all our admissions. So when we talk about a tiered approach, they are really involved in the bulk of our patients in an inpatient setting. When a patient scores a moderate risk on the tool, we recommend that the nurse care manager does an in-person assessment with the patient and their caregiver to identify, hey, they're in that middle ground, they're in that moderate risk. And they're going to make that clinical decision of, as a nurse care manager, do I need to follow this patient in an increased cadence through their stay? Or is this an appropriate patient to hand back to the team coordinator and to continue to let them follow through their admission? Or also with that other caveat with our social workers. When we look at a nurse in a social work, some patients need one or the other or both. So sometimes that assessment can make sure we have the right resource helping support our patient caregivers. When a patient scores a high risk, 2 things occur. One, the nurse care manager, again, does that in-person assessment, but they're going to continue to do the assessments throughout their stay. And most likely, this is our high-risk patients. So there's going to be some extra layer of thinking of what extra discharge planning elements can we provide to this patient to prevent that readmission or the patient having to come back to an inpatient stay. The second thing that happens is that we have an outpatient care navigation program. So when that patient is discharged, all high-risk patients fall to a report for them, and they're going to decide that care navigation program's going to outreach to the family to see if they are interested in participating in this program. This program is in its infancy for Children's Mercy. We're still trying to define and see what this care navigation program is going to look like as we move into just new models of healthcare in the United States. But we had a case scenario that I like to share. It was a patient example that, before the HARRPS research tool or the HARRPS research was complete, before we knew what was a low or high risk patient, this patient was frequently in the hospital. So if you look back at their track history, they had an admission maybe every month, every other month for a few years back. So they're a very high acuity patient and well known to us. They scored high on the HARRPS tool, which led to care navigation reaching out and getting involved with the patient. If you follow this patient's case, as care navigation got involved in the ambulatory setting, their number of admissions decreased, and they went a whole year without an admission to the hospital. So it was just, when you look at our inpatient care navigation or our inpatient care management team and our outpatient care navigation team, and what we could do when we could identify a patient and keeping them at home, that's what I think sometimes that's what the tool was about. It's not just about a care management structure, but it's also about the patient and giving them better quality of life at home, hopefully, instead of in the hospital.
That's great. And I would ask, so that's moving it into the ambulatory setting. And I would suspect you get some admissions that are long-term care in some form or fashion. I would suspect this tool is going to be really appropriate and appreciated by those folks as well. Have you had any opportunity to apply it, and that's with those institutions yet?
Not yet. Right now, it's only being completed at time of admission for our inpatient setting.
Okay.
We have considered as next steps, what would it look like if this was a tool used at time of discharge? Because some of the questions, especially if we think of our nursery setting, when a baby is born and comes into our intensive care nursery, we might not know all the answers to those questions, or those questions will look much different at time of discharge. So there's been discussion of, for certain populations, would it be more appropriate to complete closer to discharge instead of admission? And then if we could somehow find a way to automate the tool, I think that might open up some avenues in the ambulatory space.
So that's really interesting, and potentially another study, I would think.
Absolutely.
Right?
Yep.
So, you know what, as I'm thinking about that, can you talk about, for the folks that are listening, some of the places where you've published this work? I know it's been published a couple of times.
Yep. So our quality improvement project, as you mentioned before, won the most innovative award at the ACMA conference in 2017. That was a poster presentation. We also completed a podium presentation at that time, and that focus was the quality improvement. We didn't have the research data at that time. As we completed our research study, the research findings and the final copyrighted tool was published in the Journal of Pediatrics back in the spring of 2020. And we have also presented, though, a handful of times, whether that be at the ACMA conference, we've presented at local research conferences, we've presented at the local SPS to show what we're doing to focus on reducing the readmission hospital-acquired condition, or the HAC. And we're also now looking at next steps of what research will do going forward.
So that actually was one of my next questions, because certainly intriguing, I think, is applying the risk tool at discharge, because from my perspective, that helps to assure the transition to whatever the next setting or level of care would be. So I love that. But more immediately, are there some more immediate next steps that you're working on internally within your organization?
Yep. So we are going to complete our second research study in the spring of 2020. As we know, we were substantially impacted by COVID-19. And for us, that meant all non-COVID-19 research went on hold. And as our organization shuffled and learned how our new work structure would look like, it's taken a full year for us to get back to the place that we feel comfortable moving forward and have the time to dedicate to another round of research. So this spring, in the next month or two, we'll complete our second research study. Now that the tool's up and running and has been running, we can do kind of a one snapshot in time for research. So we can go and pull back pull back historical data instead of having the research study run for a whole 12 months. So with that study, we're going to look at a few things. One, can we get the same results with a different population? That will help even further validate the tool. Two, we're going to take another look at the questions. Are there any questions that we could potentially remove, but still keep the probability of predicting readmission risk the same? We don't know if that's going to be a yes or a no, but again, trying to look back at simplicity. How can we make this as simple for people to use as possible? And then the third part of that particular research study is going to gather some demographic information, trying to think of how do we look at social determinants of health? Are there specific demographic elements to a patient that are attributed to readmission risk that we might need to consider? So that's the second phase. The third phase doesn't necessarily need to potentially be formal research. When we talk about kind of cycling back to quality improvement, what would it potentially look like to complete the tool at different time points? If we completed the tool at discharge versus admission, what do the scores look like? What do they tell us, or what do they not tell us? Do they remain the same, or do they look different for our patients?
That's great. So for you personally, in terms of you've got wonderful experience as a pediatric nurse, which you can expand on, but just what did this, being involved with development and then quality improvement and a research study, you're listed as the principal investigator. Can you just talk from a personal perspective what that has felt like?
Yeah. Starting back on it, I was a nurse care manager working. So I was on the ground. I was completing the tool myself. I was at the forefront, or the patient-facing side. That was the time point that we were doing quality improvement. As the study progressed and as my role evolved, I became more involved in the clinical documentation space because, again, I got to know a lot of our informatics folks in developing a tool in an electronic health record and meeting connections throughout the hospital. So I guess for me personally, it's done a few things. One, the networking and getting to meet different people within our organization, as well as, I guess, further defining my career. If you were to ask me back when I was a care manager, it's probably it is the area I'm most passionate about. But if you were to ask me if I would ever be in informatics, I would say, no, I don't know computers. I'm not going to be there. But with this tool that led to networking, showed that I could take on a position in which I'm in now as a manager in clinical informatics and support the care management space. That's still my specialty, but now I get to work in and support care management, our home care department, our ambulatory nurse care navigators. I get to help support that whole care continuum space and really think of that big picture and how do all the settings work together. So I personally really enjoy that. It's a space where there's so much potential for innovation, especially when we look at how do we look at the patient from a bigger picture and not just episodic care? How do we keep them home and healthy? Because, as a pediatric nurse and as a mom, I know no matter how great our inpatient staff is, they'd rather be at home. And so how can we keep them healthy and at home instead of continuing to come back to the hospital?
Well, that was a wonderful summary that I know our listeners are going to appreciate. We're talking, in these sessions this year about innovation, and I think you just hit the nail on the head. It is space that you don't even know that you want to be in until you venture into it. So congratulations on just wonderful work. As we wrap up today, anything more that you would like just as a takeaway for our folks? It sounds like the tool is primarily used in your system. if folks are interested in learning more or reaching out, we can certainly facilitate that through ACMA. But any other takeaway that you would want to leave them with?
Yeah, absolutely. So again, we know the tool was published in the Journal of Pediatric Nursing, so we lose a little bit of tracking in who might have potentially grabbed that tool and used through that avenue. But we do have a website. It's childrensmercy.org/HARRPS. So it's spelled HARRPS. Through that website, you can get a hold of our research teams. So if you have any questions at all, don't hesitate to email us or contact us through the website. And we can also help if you want it built in your EHR. We can also talk about how did we build it? What would be some of our recommendations? We want to get the tool out there and used, even though we have a copyright on it. That's really just saying, hey, we want you to use what's validated and research-based, but feel free to use it. I think sometimes people see the copyright mark and get a little hesitant. That doesn't mean we definitely want people to use it and incorporate it into their systems if all possible. So again, like our website is childrensmercy.org/HARRPS, or if you want to email us directly, it's HARRPS, HARRPS @cmh.edu. And that goes to myself and a few of us that are on the research team and know the tool pretty well.
That is terrific. Well, this is wonderful, innovative work. It's exciting. I am grateful for you sharing this with us today. This podcast is brought to you by the American Case Management Association. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge afforded through ACMA membership. Gain access to discounts on national and local case management conference registrations. Available exclusively to ACMA members. Visit www.acmaweb.org/membership to learn more. That's acmaweb.org/membership. For the folks that are listening, if you've enjoyed listening to this podcast, we'd love to hear from you. Please leave us a rating and written review so we know what you think, and would love for you to subscribe to Care Transitions Today so that you can be notified every time we upload new episodes. Please stay tuned for our next episode as we continue our innovation series. Sarah, thank you once again, Sarah Bradshaw, for sharing your experience. And until next time, I'm Deb McElroy, and this is Care Transitions Today.